My name is Tzu-Fei Wang, and I'm a hematologist at the Ottawa Hospital and the University of Ottawa in Ontario, Canada. In this episode of Clot Chronicles, I would like to discuss challenging situations in patients with cancer-associated thrombosis. As we all know, malignancy is a significant risk factor for venous thromboembolism. It is estimated that up to 20% of cancer patients may develop VTE at some time in their cancer journey, which can lead to increased morbidity and mortality. The optimal prevention and management of cancer associated thrombosis is therefore of utmost importance. The red-oriented coagulants have been demonstrated to be effective in the cancer population in recent randomized controlled trials, including the Hakusei VTE cancer, SELECT-D, ATOM VTE, and Caravaggio trials. However, cancer patients have unique challenges and comorbidities that can lead to increased risk and concerns with anticoagulation. Therefore, here I want to share with you a recent paper from NATF focusing on challenging situations as part of the Cancer Associated Thrombosis program, where we choose 10 areas where there's limited or conflicting evidence to guide best practice. In the paper, we try to review pertinent data for each selected topic and provide guidance for patient management based on the best available evidence and experiences from the involved authors. Here, I want to show you this table where we summarize the 10 challenging situations on the left, and on the right is our suggestion for each scenario. The first and second challenging situations are for patients with active GI or GU lesions. Randomized control trials have shown that rivaroxaban and edoxaban are associated with a significantly increased risk of major bleeding compared to the low-heparin deltaparin. And the majority of the major bleeding events occurred in patients with unresected intact GI luminal tumors. Therefore, practice guidelines, including our opinion, would give preference to lomogaheparin in patients with active GI lesions and in whom deemed to have high risk of GI bleedings. As a Caravaggio study and also to ADAM-VT study, which was quite small, they did not show increased risk of GI bleeding when comparing apixaban to deltaparin. Some providers may feel comfortable in using apixaban in this population. However, other providers feel otherwise, given the difficulty in cross-trial comparison. Therefore, consensus was not reached. Meta-analysis also showed that there are 5 times increased risk of major GU bleeding in really all the DOAC trials. And while we still need more data to show that if GU bleedings occur in patients with intact GU luminal tumors, such as bladder tumor, this is inferred from the available data, and therefore we propose that lomogaheparin will be preferred in patients with high risk of GU bleeding, including patients with intact or unresected GU tumors, especially in the bladder, or GU manipulations, such as nephrostomy tubes. In addition, in patients with conditions resulting in decreased GI absorption, such as after gastrectomy or recent GI surgery, we also would prefer to use lomogaheparin. And next, I would like to discuss concurrent drug therapies, including concomitant use of antiplatelet agents and also drugs concerning for potential drug-drug interactions. Now, there are very limited data in the cancer population, so a lot of times we had to extrapolate from the non-cancer population. With recent data did show that in patients who are on therapeutic anticoagulation, antiplatelet agent should be and recommended to be minimized if possible for risk of bleeding. In patients who are taking concurrent medications concerning for high risk of drug-drug interactions, such as strong inhibitors or inducers, or both cytochrome CYP3A4 or a P-glycoprotein, we would prefer to use lomogaheparin or edoxaban if the drug is not involved in the PGP pathway, as edoxaban only involved in the PGP pathway. Next, in patients with other conditions specific to cancer population, such as patients with intracranial tumors, catheter-associated thrombosis, thrombocytopenia, and hematological malignancies, we don't have great data in using DOAC in these population, and many data involving small single-center retrospective studies. However, in the available data, DOAC may be considered to be used in a similar pattern as lomogaheparin. And lastly, in patients with renal insufficiency, especially with creatinine clearance less than 30, we would suggest to use dose-adjusted levodopa with potentially anti-10A level monitoring, or apixaban could be considered, in the opinion of some members, based on the FDA approval in this situation. I would direct you to refer to the full publication for more details in each challenging scenarios. I hope that this video and the manuscript can be helpful for providers facing these challenging situations. Thank you for your attention.